we are having first topic on AKI management. For that, I invite Dr. Shishir Bhai, who is Chairman and Head of Department of Nephrology at Muljibhai Patel Urological Hospital, Nadiad. He is mentor of many nephrology students. He has many international and national publications. And his special area of interest is renal transplantation and nephrology education. It's our always a privilege to listen to him. Please, Dr. Shishir Bhai.
Thank you, Praful, and good evening to all of you. And I would also like to thank at the outset Dr. Gunjan and the team from Rajkot to invite me for this session. And I'm also pleased that there are a lot of hardy souls still left in the audience. We realize that we are the last group before the entertainment program starts. So task given me to was to talk about acute kidney injury, and since I thought it's a very vast subject, limit it to a progression of a single case and see what we can understand and what you can do in the practice of when you are faced with a patient with acute kidney injury. So briefly, acute kidney injury is defined as the accumulation of nitrogenous waste products, and which is of an abrupt onset. As somebody mentioned in the very beginning that about the Kumbh Mela. So it is not that what the mouth that you take in, but what the kidney decides to keep decides you will be healthy or unhealthy. So similarly, if there is an acute retention of nitrogenous waste products occurring over minutes to hours, it is usually defined as acute kidney injury. It is about 5 to 10% in a hospitalized patient, about 60% in patients who are in the intensive care unit. And acute kidney injury is usually not a single disease. It should not be viewed as a single disease, but it should be viewed as a group of disorders which have a common endpoint or common pathophysiological mechanisms. And some management strategies can be applied universally to all acute kidney injuries, but efforts will be made to understand what is the cause of the acute kidney injury and accordingly plan the treatment for it. So to begin with, we have a case. You are asked to see a 50-year-old school teacher who has diabetes and a known chronic kidney disease. The serum creatinine remains around 2 and is admitted with urosepsis. Admission creatinine is 2.3 and has increased to 2.8 the following day, and you are asked to evaluate this gentleman. So how do you know what the kidney function is in this patient? So you use an MDRD equation to find out, and the GFR is 34 ml. If you use another equation like CKD API, it is about 32 ml. If you do the CG formula, if you remember from your school days and college days, it is about 20 to 32 ml. His eGFR cannot be calculated because his serum creatinine is not stable. So out of this, which is the correct answer, if you would want to say, or if in interest of time? So important to note is that in acute kidney injury, you cannot use any of the formulas to calculate your eGFR. So eGFR is only for patients who have stable serum creatinine that you use the formulas. But for acute kidney injury, because the kidney function is rapidly deteriorating, no formulas will give you the right eGFR. So don't use these formulas for acute kidney injury. Generally, if the urine output drops below 0.3 ml per kg, 0.3 ml per kg per hour, then usually the GFR is below about 10 ml. And in these patients, use the formula for any drug dosing or anything that is GFR below 10 ml. And whatever be the creatinine level at that point. So in acute kidney injury, don't use the formulas. So we have, as you understood, we just concentrate on the left, the first column. Most importantly, in the ICU setting, you should first monitor the urine output, because urine output tells you everything, whether the patient's hydration is okay, whether things are going all okay or not. Usually one produces 1 ml per kg per hour. So in an average 60 kg patient, you will produce about 60 ml of urine per hour. If it goes below 0.5 ml per kg per hour for 6 to 12 hours, be alerted to the fact that probably this patient is likely to go towards acute kidney injury. So do all the measures required, use the appropriate drugs, hydration required, cardiac function improvement, everything that is required to improve the urine output. If it drops below 0.5 ml per kg per hour for more than 12 hours, it is known as stage 2. And if it drops below 0.3 ml per kg per hour for more than 24 hours, or if there is an anuria for more than 12 hours, anuria is urine output less than 50 ml in 12 hours, then this patient is going into established or stage 3 CKD, stage 3 AKI. The KDIGO and others are given also because based on the creatinine, that the creatinine becomes 1.5 to 1.9 times the baseline, or there's an absolute increase of 0.3 into 48 hours. And similarly, if it becomes 3 times the baseline or becomes more than 3 times the baseline, these patients are in different stages of CKD. But most important is the urine output measurement, because that is actually a better index compared to even your KDIGO or even the creatinine that we measure. And this urine output is despite optimized all the hemodynamics that is possible to do. So important, as I said, is determine the cause of AKI. So whenever you have a patient with acute kidney injury, The first, more important, it was emphasized in the earlier talks also, history taking is the most important thing. So time to event charting is the most important thing. In all patients, you find out when did the disease start, what medications were given, when did the output drop, what events happened, what things were happening. So you make a time to review chart, and then do the urine examination. Unfortunately, many times we just find the patient has got acute urinary, but no urine examination has been done. And then you do an ultrasound, and if required, you do a renal biopsy. So as I've said it on the left side on the screen on the right side, if you see that there are 10 points that I have put, and I think this is the most important, or one of the most important slides in the whole of the talk. You must always think, why did the urine output go down? It can go down by multiple causes. It can be pre-renal. Pre-renal, the number one, it can mean anything from hypotension that the patient is having, the reduced blood pressure. It can be because of poor cardiac function. There can be massive pericardial effusion and decreased perfusion to the kidney, or there can be coarctation of the aorta, which leads to decreased perfusion of the kidney, or any of these can cause kidneys not to receive enough blood, and if it does not receive blood, it will not produce urine. Point 2 is about the beginning of the arteries, that is the main renal artery. Main renal artery, if you get an embolism over there, if it is or a single functioning kidney, you can get decrease in the urine output. If you come to the number 3, that is known as vasculitis. We had a big talk on vasculitis. So any patient who has got vasculitis, these are small vessels which can be involved, and you can get kidney injury. Similarly, the glomerulus, if you get rapidly progressive glomerulonephritis, you can get decreased urine output. Then you come to the tubules, then that is 5, and 6 you come to the interstitium, then you come to the pelvis where you can have intra-tubular crystals, and then you have the post that you can have obstruction. Obstruction can happen anywhere, right from the ureter to the bladder and to the outflow. And also don't forget about the venous system. So important is the urine examination will often tell you where the likely pathology is. If you find proteinuria, if you find RBCs in the urine, then the possibility is that you've got a small vessel disease or a glomerulonephritis. If you find WBCs in the urine, probably it may be interstitial nephritis or some infections which is causing the problem in the kidney. If you find a bland urine sediment, it can be because of arterial disease, tubular disease, or an obstruction. Generally, 2 things which cause anuria are, if you find a patient with complete absolute absence of the urine, either there is an embolism to the solitary functioning kidney or bilateral embolism to the arteries, or there is an obstruction. Obstruction is more likely, and therefore whenever patients come with no absence of urine, do an ultrasound to determine if there is obstruction or not. If no obstruction, you may do a Doppler to see if the flow to the kidneys are there or not. If that is all established, then you look about the parenchymal causes. So always, whenever you are faced with a situation where there is a decreased urine output or increase in a creatinine, find out what is the site of the lesion. In neurology, we are taught about the site of the lesion. Similar in the kidney, you must find a site of the lesion which is likely cause for the acute kidney injury. If after all the efforts you have made and still if you are not convinced what the site of the lesion is, then you do a kidney biopsy. So acute kidney injury, whenever we think about acute tubular necrosis, it is actually ruling out everything else and only the tubule is involved. That's the time when we say it's acute tubular injury. Otherwise, think about other causes also. Though acute tubular injury remains a predominant cause in the ICU, but other causes should not be missed. So now coming back to our patient, the review of the patient chart showed that he had received about 4 liters of 0.9% saline solution intravenous in the past 24 hours, and his urine output has increased from 10 to 20 ml. So because he came with a sepsis, probably there was an aggressive fluid management done, he was given saline, and there was some improvement in the urine output which is seen. On physical examination, vital signs got a blood pressure of 95/65, heart rate of 70 beats per minute, oxygen saturation of 96% at 2 liter of nasal cannula. His lungs are clear and he has a peripheral edema of about 2+. So the question is, what would you recommend to do? Continue with the volume expansion because his urine output has increased significantly from 10 ml to 20 ml. Add norepinephrine to increase his systolic blood pressure to about 105 millimeters of mercury. Continue with volume expansion and add norepinephrine as well. Start a trial of intravenous furosemide which could help manage his fluid overload. So in the interest of time, because, and since people are not ready, we can, most of the times, once the blood pressure is around 90 or 100, and if you're given sufficient amount of fluid, if the patient is not passing sufficient urine and has already got a 2+ edema, in this situation, patient is already going for volume overload. So in this situation, you should give them a trial of a megadose diuretic or a start an infusion of diuretic and see whether we can manage the volume and then see whether it's going to establish acute tubular injury or not. So once, don't push with the fluids beyond a certain point, because most of the times you have seen a lot of patients get waterlogged. So what is we do is that whenever you give sufficient amount of volume, the blood pressure is reasonable. That is about more than 100 or 90 millimeters of systolic or mean arterial pressure more than 70, then give them a mega dose of furosemide, that is give 1 milligram per kg IV furosemide. Or if patient is already on furosemide, you can inject it up to 1.5 milligram per kg IV. In the 2 hours, if the urine output is less than 200 ml, this is furosemide test negative or non-responsive, and probably the patient has gone to establish acute tubular injury. If there is a flow more than 200 ml, then probably it seems that this patient is still volume responsive, and you might consider continuing with the fluid, or you might consider adding some norepinephrine or something to this patient. So this is a good test to know. Furosemide, you must remember, does not improve the outcome of the patient. So furosemide is not a treatment for acute kidney injury. It is this year just a test for it, or sometimes in a patient you want to use it for volume management, but it does not prevent acute kidney injury, nor does it be helpful in the treatment of acute kidney injury. So, and what about intravenous fluids? So early goal-directed therapy, which was very popular in the past and now still some people are continuing, but in a septic patient received intravenous crystalloids, inotropes transfusion according to predefined protocol had no effect on the mortality or renal replacement surgery. So early goal-directed therapy, which was very popular some years ago, is no longer recommended because patients become volume overloaded. Always see whether given a sufficient volume in the beginning. If the patient is not responding, you may try it about giving some inotropes. If not responding, do the fast test, give them furosemide and see. If not responding, then it's going to probably establish ATN or acute tubular injury and manage accordingly. So although administration of intravenous fluids in patients with sepsis and or hypovolemia beneficial initially, fluid overload can happen in them and can more harm than good. Many of these patients, when they go into the ventilator also, they will not come off the ventilator because they've been given excess amount of fluid. It's very important to restrict that or the fluid. So as you can see here, that whenever there is given excess amount of fluid, you can have congestion in the brain, the lung, the hepatic congestion can happen, renal congestions can happen, and tissue edema will also happen. Gut edema will also happen. These patients also not have nutritionally poor. So in ICU, we should not find patients who should be waterlogged. A mild edema is okay, otherwise they should not be waterlogged. If they are so, then we must take measures to dewater these patients. So what about the fluid resuscitation strategies in a stress response? So in the first 6 hours, you might do some aggressive fluid management, but from 6 to 36 hours, you must actually start decelerating. If they're not responding, otherwise all the fluid that you give will go into the extravascular compartment or the interstitial compartment, patient will have a lot of edema. And beyond that time, about 36 to 48 hours, you have to stop administering IV fluids and start thinking about how can I mobilize this excess fluid which I have given if the patient is not passing good amount of urine. So now the second question that comes up always in patients with urosepsis or any form of sepsis is to give normal saline or a balanced fluid. Balanced fluid is usually ringer lactate. And now there's increasing evidence that if you're using a large volume of resuscitation fluid, it's better to give them ringer lactate or the balanced fluid that is containing more because it contains less chloride. Normal saline contains about 140 millimoles of chloride, whereas the normal chloride in the blood is about 105. So if you give more chloride to this patient, they can become acidotic, and therefore their thinking is that more to move towards the ringer lactate of it. We must also realize that ringer lactate contains only 4 milliequivalents of potassium, so don't worry about potassium. Even the patient is oliguric when you're giving them ringer lactate. However, you must note that if you're using a very small volume, there is a liter or two for resuscitation, then it doesn't really matter whether you give normal saline or ringer lactate. But if you're using large volumes, then better to use ringer lactate in these patients or other balanced fluids. Again, what should be the goal of blood pressure levels? And as we discussed in the case also, a mean arterial goal of about 65 to 70 is actually enough. That is about a systolic blood pressure about 90 to 100 is good enough. Don't try to raise it up too much by using too much of fluid or too much of inotropes in them. And because in these studies it was shown that it did not make any difference when you keep the blood pressure around 90, that is the mean arterial pressure about 65 to 70, rather than bringing it up to 80 to 85 and using multiple inotropes is usually not really very necessary in these patients. What about the number of drugs which are tried for the pharmacotherapies of acute kidney injury, like the diuretics, calcium channel blockers, erythropoietin, dopamine? Dopamine has no role. So low dose dopamine was touted that you may use it in the perioperative period or has got no role. All these insulin like growth factors, thyroid hormones, N-acetylcysteine, statins, aminophylline, all these drugs, none of these drugs have been found to be any use in patients of prevention or treatment of acute kidney injury. So forget about pharmacotherapy of acute kidney injury. There is still no drug which is available for it. Only thing is required is to maintain the hemodynamics, recognize the patient going into acute kidney injury. If it goes into acute kidney injury, gets into shutdown, then therapies to manage after that should be done. So this patient, again, 2 days later, the patient remains oliguric despite a trial of furosemide, and his serum creatinine has increased to 5.5. Blood pressure has become 105 by 75. He has peripheral edema 3+, oxygen saturation 91% of 5 liters per minute by nasal cannula. And what is the time to start the renal replacement therapy? So because the time has now come, you're given enough of furosemide, you've tried enough of fluid and everything, patient is still not passing urine, actually it's gaining fluid, he's already got 3+ edema, so what's the time to start renal replacement therapy? So there are some indications which are very emergency indications. That patient has got pulmonary edema with non-responsive diuretic, they should be started on dialysis immediately. Metabolic acidosis, the arterial pH of less than 7.2, hyperkalemia of potassium more than 6.5, poisoning with dialyzable toxins. Of course, in this patient it's not relevant, but this could be a cause in some patients like methanol poisoning, salicylates or lithium, they can be dialyzed. Urgent whenever there is a uremic encephalopathy or uremic pericarditis. Now the planned one, where there is a lot of discussion happening, if the patient is oliguric for more than 24 hours or anuric more than 12 hours, or creatinine more than 10 or urea more than 200, should he be dialyzed or not? Nowadays the thinking is that too early a dialysis is not really required. If there is no volume overload, no hyperkalemia, no bad acidosis, then you don't really require renal replacement therapy in the first 24 hours. You can delay it for 36 to 48 hours, see if by optimizing things the patient start passing urine or not. And the evidence shows that in these patients about 3 out of 10 may start passing urine and they might be avoid the need for dialysis in these patients. Despite all these adequate things that you do for about 36 to 48 hours and there are no danger signals, and still if the patient remains oliguric, that is beyond 48 hours or so, then you must consider renal replacement therapy. So this patient was asked that what type of renal replacement therapy would be best in these patients, because there are multiple modes of renal replacement therapy. Given the role of sepsis in development of AKI, continuous CRRT is preferable to intermittent dialysis for this patient. If CRRT is selected, the prescribed dose should be 35 to 40 ml per kg per hour. CRRT and ISD have similar clinical outcomes, and RRT can be postponed until the patient develops clear signs of uremia. So what would be the most appropriate answer? So in this case, the answer C is the most appropriate, because CRRT and intermittent hemodialysis, both of them, because this patient is reasonably hemodynamically stable, one could consider both the therapies to be equally good. There's no need to do CRRT in every case of sepsis, every case of acute kidney injury, because it is expensive and there are some problems with it also. So you can remove the fluid and you can remove the uremic toxins by two technology. One is what is known as the convection. Convection is putting pressure onto the blood side, and so you along the membrane you remove it out. You will see in the top of that slide, and which also removes some middle molecules, no molecules and water. Another is diffusion. Diffusion is that you run the dialysate fluid, that is you run the dialysis fluid, and that is a standard dialysis, and you remove the toxins and the fluid. Now, if you can see that intermittent hemodialysis is usually done for a short period of time, and the CRRT is done continuously over 24 hours. And there is something known as something in between intermittent hemodialysis and the CRRT, that is known as the prolonged intermittent continuous renal replacement therapy. That is what is called also known as a SLED. You must have heard SLED. SLED is same as PIKRT, that is low efficiency dialysis. It is actually a hybrid technology where what you do is you run the patient for 6 to 12 hours. You can done daily, every day you can do it. The blood flow kept is about 200 to 300 ml, and the dialysate flow normally it is about 500 ml per minute that you run. In the low efficiency or PIKRT, what you run is about 200 or to 300 ml per minute. So it's a very low efficiency dialysis, and now this is becoming more popular because it is cheaper. It is at the same cost as dialysis, or maybe little bit higher compared to the CRRT cost, and the results are quite equivalent. So this is the therapy which is more popular. So more diagrammatically, if you show that the CRRT uses a low blood flow, low dialysate flow, and you run it for 24 hours, you do it 7 times a week, whereas intermittent you normally do it 3 times a week, 4 hours, and high blood flows and high dialysate flow. And SLED, which is in the between, you run it at a low blood flows, low dialysate flows, you can do it intermittently from 8 to 12 hours, and you can get an ultrafiltration about 0 to 400 ml per hour, and you can do it 4 to 7 times a week. So this is very popular because you only need a standard dialysis machine, standard dialysate. You don't need any fancy equipment. Your usual dialysis technician can run it for you. It can be done that way. So what about another important aspect of AKI management is about the nutrition and glucose. Don't forget about it, because AKI is in a hypercatabolic state, and so all patients should be put on sufficient enteral nutrition. Here in acute kidney injury, don't restrict the protein. In fact, actually they require higher protein diet. Maintain normal calories to these patients, so don't restrict anything. Only restriction that you probably need to do is to reduce the amount of potassium, so don't give them fruit juices or fruits, but otherwise you can give them everything to eat if they're taking enterally. If enteral is not possible, then you can use parenteral. Again, normoglycemic studies have shown that don't try to induce too much of hypoglycemia in this patient in the ICU. Try to maintain a sugar between 150 and 200 is good enough. Don't try to achieve too low a sugar in these patients. So the case was continued, and this patient, 2 weeks later, the patient begins to recover kidney function, is discharged from the hospital with serum creatinine, and that is stable at 2.5. Normally, how do you know to stop the renal replacement therapy? Generally, when the urine outputs goes beyond 600 ml to a liter or so, that's the time when you start thinking whether the kidney function has started improving. You do the creatinine and see that without dialysis, the creatinine starts falling. That means the patient is improving, and you can hold off the dialysis or skip a dialysis and see how things happen, and then eventually take it off as the patient's function improves and the output starts improving. So this patient improved and a stable creatinine of 2.5, and he asked you about the long-term impact of AKI on his health. So the question is that what is the best way to respond to his stated concerns? Because this patient had an acute event due to urosepsis, which is now fully treated, the AKI has got no meaningful impact on the course of his underlying CKD. His risk of future dialysis dependency has increased significantly after the episode of AKI. I think. Anyway, this is the last, almost the last slide to it. So the question is that every AKI episode actually leaves some injury to the kidney, and they are at a risk of having little rapid progression. After that, so all patients of AKI should be followed up to see whether, how are they doing at the renal function, how are they doing with their hemoglobins, their other divalent ions and everything. So it's not that when the episode of AKI is over, everything is good, but you must continue to follow these patients. So in the summary, so patient that's at risk of AKI, you monitor the urine output. Don't forget not to monitor urine output. Do serial serum creatinine, correct hypovolemia, avoid nephrotoxins. If they develop AKI, investigate for the etiology of AKI, treat specific causes as applicable, and if the stage 1, review all the medications, see through it that they're not getting any NSAIDs, any aminoglycosides, radiocontrast, or any drugs which are harmful to the kidneys. And then if they do develop further AKI, then evaluate the need for RRT, and you can consider the type of RRT depending upon the patient profile. And even if the patient recovers, you must continue to follow these patients because they are at a risk of getting a progression of the chronic kidney disease. I think I'll end here, and thank you all for a very patient listening to the questions.